So the next presenter will present on anticoagulation control in AF patient with chronic kidney disease receiving warfarin for stroke prevention. We have Dr. Hanis Hanum Zulkifli from UITM. I would like to invite Dr. Hanis. Please, Dr. Hanis.
Hello, my name is Hanis, and I'll be presenting on a topic on anticoagulation control in atrial fibrillation patients with chronic kidney disease receiving warfarin for stroke prevention, the West Birmingham AF project. So these are the contents that I'll be delivering throughout the session. So as an introduction, the prevalence of AF in CKD is estimated to be around 12 to 18% compared to 7 to 8% in the general population of more than 65 years old. Hence, these patients require effective anticoagulation to prevent the risk of stroke. Now, the effectiveness and safety of warfarin is optimized in AF patients with CKD when the INR is between 2 to 3. However, anticoagulation control comparing different categories of kidney function has not been well assessed, although poorer INR control may be more likely in AF patients with chronic kidney disease. Now, because of that, we tend to our main objective is to examine the quality of anticoagulation control via TTR among AF patients with different categories of kidney function who are prescribed with warfarin therapy for stroke prevention. So as you can see on the slide here, table 1 shows the different how we categorize our AF patients with different categories of kidney function. So we actually use the KDIGO and the NICE guidelines as a reference. And after combining some of the patients, we ended up with 3 groups of patients: those with normal kidney function with an EGFR of more than 90, those with mildly decreased with an EGFR of 60 to 89, and those with mild to moderate and severe kidney disease with an EGFR of less than 59. Now, this is how we conducted our study. So it's a retrospective cohort study whereby AF patients on VK therapy were selected from a database called DAWN. So initially we had 2,400 patients. After exclusion, our final cohort consists of 974 AF patients with different categories of kidney disease. So we had 30.7% with normal, 50% with patients who are mild, and 35.9% who are in moderate to severe kidney disease. So our outcome was to look at the measures of anticoagulation control via the TTR with the Rosendahl method, and as well as the PINR method. Now, looking at the results, here's the demographic characteristics. As you can see from the table, patients with EGFR of less than 59 were significantly older. Majority of them were female and were white of origin. Again, those with an EGFR of less than 59, a higher proportion of them had heart failure, hypertension, stroke, as well as anemia, whereby a higher proportion of patients with a normal kidney function had lung disease and they were smokers. As you can see, there's no difference in the types of AF presented in the population. However, those with poor GFR were significantly prescribed with ACE inhibitors and as well as diuretics. They had higher CHAPA score and they had higher HAS-BLAD score. Now, this slide looks at the main results of the study, whereby I looked at the anticoagulation control among different categories of kidney disease. Now, good anticoagulation control is defined of a TTR of above 70, and the mean TTR in the whole cohort is only 65. And as you can see, there is a non-significant higher trend of TTR in those patients with mild and moderate kidney disease. However, when the TTR was calculated by the second method, you can see a significantly higher TTR in patients who are in the mild and moderate kidney disease as compared to the normal disease. And surprisingly, those with normal kidney function had a higher proportion of subtherapeutic INR as well as INR of above 8. Now, despite the challenges faced in managing AF patients with CKD, many studies have shown the benefits of VK therapy in AF and CKD patients in terms of reducing TA, bleeding, cardiovascular hospitalization, and of course death. Now, SPORTIVE 3 and 4 trials have shown that the mean TTR is significantly lower in those with CKD as compared to those with normal kidney function, as well as the Swedish registry showing the same thing, whereby lower mean TTR was seen in those with CKD compared to the normal. However, our results did not show a similar trend whereby we can see a non-significant higher TTR in those with impaired kidney function, and when and this trend was statistically significant when the PINR method was utilized. Also, subtherapeutic INR and the presence of at least one INR for both age was significantly more prevalent among AF patients with normal kidney function. Now, perhaps in this cohort, AF patients with concomitant kidney disease, they are well managed by a dedicated anticoagulant service, thus resulting in a similar or at least better anticoagulation control compared to patients without kidney disease. It could also mean that the presence of concomitant kidney disease is served as a flag to those anticoagulation services that extra care and attention is given throughout the entire monitoring period. Thus, this results, in a better TTR in those with kidney disease compared to those without kidney disease. So, as a conclusion, there was no significant difference in mean TTR among AF patients between different categories of kidney function. However, subtherapeutic and INRs of above 8 was greater among patients with normal kidney function than those with mild and moderate to severe kidney disease, perhaps reflecting a more strict monitoring among AF patients with kidney disease. With that, I thank you.
Thank you very much, Dr. Hanis Hanum, for a great presentation. So, actually, this study is done in the multi-center, one center. Hanis.
It's one center. Thank you for the question, Dr. Norizin.
Which center is it?
It's in Birmingham, City Hospital in Birmingham, UK.
So apparently still there are many patients on warfarin over there, isn't it?
Yes, no, it's actually, this study was actually from a database of patients who are on warfarin from the 1990s until about 2014. So it's we were at the transition of changing to NOAC at that time, so we still had a cohort of those with warfarin.
Yeah, because nowadays is the era of this DOAC or NOAC. Nowadays, even patient with low GFR, so they tend to start on DOAC instead of warfarin because of the related complication and then the feasibility, all those things. And then call even more evidences on this called NOAC in patient with renal failure itself. So what is your take in the presence of DOAC in the relationship with your study? Do you think your study is still relevant for the current practice?
Yeah, I think it's very important question to be raised. I know NOAC is being used and uptake widely, but then in the KKM setting, we still do prescribe warfarin due to obvious reason and cost. So, what I would like to say is despite the availability of NOAC, we still do use warfarin, and hence my result could highlight that those who receive warfarin still have better outcomes if they are really well managed by the anticoagulant services.
So what will be the implication of your study towards the clinical practice, our clinical practice?
Yeah, because like I said, we are still heavily using warfarin, especially in most KKM hospital. I would like to highlight that even though we all know that CKD is a challenge, to manage, but with proper and a thorough follow-up and monitoring, good outcomes can be seen among these patients.
So, okay, I think it's good. Thank you very much, Dr. Hanis Hanum Zulkifli.
Thank
you. So, yeah, and all the best. I will leave it to Dr. Imran again.
I think thanks, Dr. Hanis, for your presentation. I was actually a fellow in Sandwell and West Birmingham Hospital. I did all your, that's why, because I noticed that your co-authors are Professor Lip, and I was Professor Lip's fellow. I was Professor Lip and Professor Kirchhoff's fellow. So a bit weird, a bit of an interesting warfarin because they are very NOAC heavy.
Yes.
Nonetheless, let's move on to Dr.